Before I hand over the mic to Dr. JPS Tulsi to introduce our honorable speaker, I would request Mr. Ranveer Singh to come forward and introduce the center to all of you. Please, Mr. Ranveer Singh.
And on advanced surgical andrology procedures. And at DIYOS, we do specialize in all sorts of urology and andrology procedures. But apart from that, we do focus patients for ENT, orthopedics, clinical psychotherapy, and apart from that, all major laparoscopic and general surgeries. And the primary focus is on male fertility and erectile dysfunction. It includes overall men's health. So this is all we are focusing. So we would like your support and guidance, to proceed it, to make it better. And thanks, Dr. Chauhan, for introducing us. And I would like to call Dr. Suri to please take over. Thank you. Oh, sorry, I'm really sorry.
Thank you, Dr. Chauhan. So as we enter our 11th year of continuous Wednesday CME, I have the pleasure of having Dr. Vineet Malhotra with us. We all know him, but to the 70 lakh odd audience, I have to introduce Dr. Vineet Malhotra. This is being telecast and globally for about 70 lakh viewers. So just a brief introduction about him. So he has over 15 years experience as an andrologist and urologist at Gujarat. An expert penile surgeon and microsurgeon, trainer for holmium laser prostate and stone surgery. It's probably one of the best holmium laser he has at his center. People are doing TRP, but this is probably the latest. We don't have to do TRPs. So he's a convener surgical sperm retrieval workshop for Vision 2017. Convener live operative andrology masterclass for urologist New Delhi 2107. Invited faculty for international and national meetings on andrology. Advisor board member of Men's Health Society of India. Invited international faculty for andrology masterclass at Indonesia. Invited international faculty at Kathmandu for andrology workshop. Invited faculty for Fertility Protect 2017. And author for male infertility chapters in textbooks, articles in national and international journals. Friends, what is surprising is that he is doing 60 to 70% of the penile implants which is being done here in the country. 60 to 70% implants he is doing. And 4 to 5 cases a month. And has done over 500 penile implants, which includes a lot of doctors. Penile implants for a lot of doctors. Isn't that surprising? And the eldest penile implant he has done is at the age of 78. And the youngest at the age of 22. Wonderful, sir. He has his center at Sataji Enclave, and what can I say? He's probably one of the best andrologists in the country, Dr. Vineet, sir. And he's going to talk on what is new in andrology today. Sir.
Thank you, sir, for an extreme. You will come across these patients very, very frequently, but it's just that these are things that are never spoken about. And today we'll try to take a slightly different path. We'll try to talk about surgical andrology, which actually I think very few people talk about or discuss this about. You'll find these patients in practice every day. Infertility patients which are related to the male factor. It's actually known that male factor will in some form account for 50% of all infertility, which means 20% by singly the factor that it's only male, and 30% in combination with male and female factors. So it's an extremely important factor for infertility. But eventually realized that this is something which is related to the male reproduction, and they gave the name spermatozoa. And things evolved from there. So crude ART was done using untreated samples. At that time, you never created the pellets. You took the sample and you just went ahead and did an intravaginal insemination. And then eventually, more advanced things. The initial testicular biopsies were all diagnostic only, which means they would only help in understanding why there was infertility. Not to a great extent, but the only reason to do a biopsy was to understand whether there was any spermatogenesis or not, and if at all, some evidence of what the histopathology was. You couldn't use that sperm for anything. That actually happened when ICSI came in. ICSI came in actually in 1992. De Broglie was the first person who brought in ICSI. And till that time, all the retrievals from the testes were diagnostic. Which brings us to the most important factor whenever a patient walks in. We will be slightly different here. I'll try to be clinical because theory will not, it will get too confusing, and we'll try to behave as if the patient has walked into your clinic. And what will you start thinking whenever the patient walks into the clinic? So the first thing that comes to my mind when a patient for infertility has walked into the clinic is whether I'm dealing with someone who has some problem with sperm formation or has no sperm at all, because that makes a huge difference to how I can manage him. And that is called azoospermia. So if he has no sperm in the ejaculate, that is azoospermia. And it's important to understand that this is absolute. So if you see occasional sperms, if you see a few sperms, that's not azoospermia. If you centrifuge the sample and you find a few sperms, that's cryptozoospermia, it's not azoospermia. So azoospermia is absolute, which means there are no sperms present. You centrifuge the sample, you still get no sperms present. You check the sample again after a gap of a week or 10 days or a month, and you still get no sperms in the ejaculate. That's absolute. And when you have azoospermia, or you have zero sperms in the ejaculate, then the next thing that should come to mind is there sperm formation happening in the body, or is there no sperm formation happening in the body? Because if there is sperm formation happening in the body, it means there is some blockage somewhere in the passage of these sperms, and that's why he is azoospermic, or he does not have sperm in the ejaculate. If he does not have sperms in the formation in the body at all, then you're dealing with something far more severe. We'll talk about how this is also dealt with, but then you're looking at something which is more severe. The prognosis is not as good. You'll probably be able to do less for this person. Now, if you find out that there are sperms in the testes, which means it is getting formed, how will you find that out? You can also find that by clinical examination, because the testes will be full, epidermis will be full, vas will be relatively full, and he will have all other normal parameters on examination. So once all of this has been found, you are suspecting him to have sperm formation within. You do a quick biopsy and you prove that he is actually forming sperm within, and you label him as an obstructive azoospermic. This used to be the pattern before. Nowadays we don't even do the biopsy as a diagnostic procedure. We actually do it only in a place where we can also freeze or use the sperms for therapeutic purposes. So this may be someone. So actually the commonest cause of obstructive azoospermia is vasectomy. So in spite of the fact that vasectomy in our country is not now very popular, but it is still the commonest form of obstruction. At one point in time it was forceful vasectomy, which was the commonest cause in our country. I think everyone knows when that was. And the other causes are bilateral absence of vas deferens, ejaculatory duct obstruction, and epididymal obstruction due to infection and inflammation. The first and the last are actually the surgically correctable options, which means by a microsurgical procedure, you can reverse a vasectomy. And reversal of vasectomy is actually, again, a very absolute procedure, exact procedure. and we have results which are usually greater than 95% for patency and recovery of sperms. So this is a very standardized procedure with very good outcome if done properly microsurgically in the appropriate method. The VEA or the vasoepididymal anastomosis is a far more complex procedure. It involves tubes which are far thinner than the vas deferens, and hence standard results out of, or successful results out of a vasoepididymal anastomosis usually are at about 50%. In our country, they are actually even lower. They are at about 30%. But our center, for that matter, has had a very good record. We are somewhere between 70 to 80% for our outcomes for VEA also. So it absolutely depends on how you do the procedure. But that's the surgical correction. So it may be reversible if you have a reversible option. Sperms are almost always found because sperm formation within is normal. It's not a disease within the testes, it's a blockage somewhere. So if you're going to poke the testes, you will always find sperms there. And then you have non-obstructive azoospermia. And this is where you may actually have very, very few sperms within the testes. They don't reach the threshold where they can then go into the tract for ejaculation. So maybe there may be very few sperms in the testes, but they cannot reach the ejaculate. And usually it's either because of the testes not having developed, you have primary testicular failure, or the gonadotropins did not allow the formation or the initiation of spermatogenesis and then persistence of it. Very rarely it may be because of varicoceles. In this, by simple aspiration, you very rarely get sperms. You need to do some complex procedure to actually get sperms in. We are doing a little bit of the background because when I talk to you about what is new now and what you do, you will need to have these bases to understand that. So the indications for retrieval of sperms, we will talk about other surgical procedures which involve reversal and varicocelectomies. But we are right now talking about finding sperms for IVF or ICSI. And the indications are either obstructive, which is not reversible, non-obstructive in all cases because you can't correct it. Sometimes those where you will find a semen report telling you that all the sperms are dead, they are immotile. So in those cases also either immotile or dead sperms. And occasionally in an IVF center you get a frantic call, fellow's been ejaculating perfectly, but on the day of the IVF ICSI, on the day of the egg pickup, the IVF center doctor tells you he just is not ejaculating. And that's an emergency situation because the wife has been stimulated, the eggs are ready, and you can't get a circulation. When we do this sperm retrieval, what are the goals? We want to obtain the best quality of sperms possible. We want to have enough sample to be able to freeze it. We want to minimize damage to the testes during this process by the simplest method possible. And there are a variety of methods. We'll quickly go through them. I'll show you how simple it is to retrieve sperms. So we'll start with the simplest method, which is called PISA. PISA because you do percutaneous epididymal sperm aspiration. It's very simple. It's blind, but it's relatively non-invasive. You don't want to do this procedure where you want to do a surgery for reversal later on, but otherwise this is an excellent procedure. And it's as simple as this. So I'm holding the epididymis between the index finger and the thumb. That's where it is fixed. We take an insulin syringe with a little bit of media and you aspirate and you just create a few punctures into the epididymis. The important point here is actually to localize the epididymis. If you've done that, then everything else is very, very simple. And once you've done that, you'll find some amount of fluid coming into the chamber. This fluid actually contains millions of sperms because this, in obstructive azoospermia, you have a lot of sperms. And so you'll get a lot of sperm in this sample. So, simple procedure to do that.
In which region?
We'll talk about it. I'll come to questions later. So, the other method is to do a needle aspiration biopsy. You can do this also for obstructive cases. You can also use this for non-obstructive azoospermia. Now this is also a simple procedure, and sometimes, especially if you don't have the experience to be able to identify fix the epidermis, this is far simpler because the testis is much bigger. You'll always get sperms here. And this is also a very simple method. This is also a needle biopsy. It's different from a fine needle aspiration cytology where you get only fluid as aspirate. Here you will see that we are actually able to get a good core of tissue. So you can get huge number of sperms, you can get a biopsy, histopathology, all of that by using this butterfly needle. We use an 18-gauge butterfly needle. And again, it generates enough negative suction vacuum to be able to get a really good volume of tissue. You will see when I finish this procedure, there's enough volume of tissue which is available then. So you maintain this negative suction when you pull out the butterfly needle. And when I pull it out, you see this huge chunk of tissue. This is all testicular tissue. And we are able to get a huge number of seminiferous tubules that will come out with this, and the amount of sperm that you get and the tissue that you get is quite satisfactory. Now for obstructive azoospermia, these are excellent techniques. For non-obstructive azoospermia, you have slightly different techniques where you need to probably do more punctures or you need to do more invasive procedure, which is why I said whenever you see no obstruction as the cause of zero sperms, you're looking at complex procedures. And this looks simple, but you have to repeat this procedure almost in up to 20 to 30 places over the testes. It's like a mapping procedure over the testes. So it's far more complex than it looks. Though it's a simple procedure in the sense that we're going to use a needle to actually create a hole in the tunica albuginea, put in a prong of the microvascular forceps and just pull out a tubule from the surface and examine this tubule. But you've got to repeat this all over the testes at multiple areas. It's avascular procedure. It is blind in the sense that you will only sample the surface tubules. If you want to do a more rigorous sampling, then you have to actually go in for a more complex procedure which is called a microtese. You will hear all these words. The reason to mean. Microtese actually means that you are going to split open the testes and examine every tubule inside the testes under high power magnification. We use up to 25 to 30x magnification to examine each tubule because these may be as tiny as 100 microns, 50 microns in size. So you split open the testes, you bivalve it, and you examine each tubule, and then you find these larger tubules which are more opaque. These are the ones that usually will contain sperm. So you can actually do a bit by bit examination of the entire testis to actually find sperm. So you can see this is practically a 2 centimeter testis that is being operated here, and it is an invasive procedure because you are actually going to bivalve the entire testis to be able to do that. Once you bivalve the testes, you are actually going to look under high power magnification to see which are the tubules which are better in size. While doing this, you have to preserve the vascularity of the testes. So, overall, an extremely invasive procedure. The chance of finding sperms in non-obstructive azoospermia after having done a procedure like this is between 20 to 30%. Then after that, these sperms will be used for ICSI. When you have retrieved sperms by this and you had a 30% chance of finding sperms, then in ICSI, the chance of getting success out of that is another 30%. So you actually overall success rate is about 10%. So we must know this and we must counsel our patients when we do a procedure like this that your overall chance that you will get success is about 10%. The cost to it, to IVF, ICSI about 2 lakhs and this procedure about 1 lakh is going to be about 3 lakh rupees for the 10% chance. So those that are committed to only using their sperms or those that want to have one attempt at using their sperms are only counseled. Otherwise we tell them please go ahead and use donor. It's far simpler to use donor sperm and get away by a simple method like IUI. So essentially for extremely difficult cases, those cases where you have otherwise a very little chance, these are things that have become available only recently and done appropriately in very, very few select centers. Otherwise, inappropriately done, you can actually lose the testes. We've seen several cases where the testes have been lost where this was inappropriate. operatory done. So we know that it will be retrieved in almost all men with obstructive azoospermia. This is slightly higher in terms of what the European guidelines and the American guidelines mention, because they do this procedure for all non-obstructive azoospermics, and even classify some of the latent cryptozoospermics as non-obstructive azoospermics. Our experience has shown that the rate is closer to about 30%. This, we can skip this slide, it's fairly unimportant. So essentially, again, this is some of the important questions that a patient might ask you is, how many biopsies are you going to take? What is going to be the future plan, or what is going to be future implication? So it's important to understand that if we are doing needle biopsies, don't proceed more than 3 to 4 biopsies. And usually these patients will have some degree of testosterone deficiency after the procedure. So if both the testes have been operated by a micro-TZ, there can be profound testosterone deficiency for 3 to 6 months. And that's something that we counsel these patients before doing this procedure. We now usually do this in a single stage procedure, which means we start with needle aspiration biopsy. If we don't find sperms, we proceed to an SST procedure. If we don't find sperms, we proceed to a micro-TZ, all in the same setting, so that we can increase the chance of finding sperms in such patients. For obstructive azoospermia, ejaculatory duct obstruction, you can de-block by doing a resection of the ducts, or you have vasectomy reversal, or the vasovasal anastomosis, and the vasoepidural anastomosis. I put in this slide only for the fact that if we can show, how fine this looks. So actually the video will not play here, but yeah. So this is actually within where you will see the epidermal ductule, and you're seeing here, this is actually the vein flow, which is 24 gauge, and the artery. So you can see this is 10-0 suture that we use here. Extremely fine. These are very, very fine ductules, and it's actually quite a complex procedure. It requires a great degree of skill and practice to be able to do this successfully. This is very infrequently performed and at very few centers. Finally, something that you come across with far more commonly, so we've discussed the uncommon ones first, is varicocelectomy. And the problem that is in mind, or the question mark which is always there, is should we operate or should we not operate? And this is very, very controversial. So if you will attend a forum which is where the speaker is a gynecologist, she will tell you it should not be operated. And since I'm a urologist, I will always tell you that it should be operated. But there is some rule to it. This slide will come later. When should it be corrected? And there are guidelines to it, which means that there are AUA, EAU, and even the ASRM, the Society for Reproductive Medicine, which has come out with guidelines. And they have these simple guidelines. One, it must be a clinical diagnosis, not a diagnosis of ultrasound. We don't even do an ultrasound until unless we have a clinically palpable varicocele and we want to document before surgery. That's the only indication of doing an ultrasound for varicocele. Otherwise, we don't do ultrasounds for varicocele. So it must be a clinical varicocele. The couple has infertility, where the female partner is either normal or has correctable factors. And finally, in the male, there is at least one semen factor which is abnormal. Nowadays, this parameter includes advanced sperm function tests also, which means even DNA fragmentation is taken as one of the parameters which may be abnormal in such cases. So if that happens, then you do a varicocelectomy. And the next question is, what kind of varicocelectomy? This was a study which compared various types of varicocelectomies which are done: laparoscopic, open surgery, embolization, and microsurgery. And you will realize that in the laparoscopic group, huge number of recurrences, fairly high chance of arterial injury, and complications. So not a procedure which is preferred to be done laparoscopically. In spite of this, there are still a lot of centers which will do a laparoscopic varicocelectomy. Embolization also, which has been spoken about a lot of times. In fact, one of the biggest problems with embolization is you can't embolize all the veins, and so you will find this unperformable in a significant number of patients. Recurrence is fairly high and fairly high complication rate. So the actual acceptance thing is the microsurgery. You will find very, very low recurrence rates, complication rates. There's practically no arterial injury. In fact, now we've started using intra-arterial Doppler, and that has even further reduced the chances of injury. I'll just quickly show you a video which I'll try to fast forward. The Doppler probe. So the Doppler probe actually will give you that sound effect of an artery pulsation, and you're able to then distinguish between the much smaller veins and the artery, because sometimes the artery will go into spasm. You will not even... About incidence, we must know what is common and what is uncommon. So varicocele actually is the most common surgically correctable abnormality for male infertility. And
that would be what, about 35% of the people who are infertile?
35%.
Would you say that, or what? What is the figure?
So it is close to 35%,
right.
Close to actually 30%.
Okay.
Not all of these will require surgery though.
Right, yes. So who would be needing surgery in case of varicocele?
So as I mentioned, the guidelines are very clear. It has to be clinically palpable varicocele. The couple must have infertility. In fact, there is a variation in two divisions. The Americans and the Europeans have a difference. Americans say 1 year duration of infertility, whereas the Europeans say that the couple must have 2 years duration of infertility. The female must be fertile or have correctable factors, and the male must have at least one semen parameter which is abnormal.
Right. So, talking about the ejaculatory duct obstruction, this is a treatable cause, but difficult to diagnose in case of there's a partial obstruction.
So this is
ultrasound probably is not so confirmative as MRI would be. Just
ejaculate. So the volume of semen usually in these men is only about 0.5 ml. When it is examined, it is found to be acidic in nature. Now, again, an important thing, because in most cases where you're looking at either obstructive or non-obstructive, the normal semen we know is alkaline. The third very, very important thing which is not tested by the labs is the fact that fructose is something which is going to be absent in these cases. Absent in this and absent in congenital bilateral absence or vas deferens, because it is something which is generated along the seminal vesicles. Now, if you find these three factors, in your mind you've thought this is either absence of vas deferens or ejaculatory duct obstruction. The absence of vas deferens is something which is a clinical diagnosis. You are very easily able to identify the whole sign that vas is present or absent. So now what remains is ejaculatory duct obstruction. Commonly, what are the important ejaculatory duct obstructions? There are two types. There is central and there is lateral, which means, so the ejaculatory duct, if we know our anatomy, actually is something which is running right through the prostate, and it opens into the urethra, right in the prostatic urethra. The central ejaculatory duct obstructions are going to cause this large cyst, central cyst formation in the prostatic urethra. You're going to see that. So when you do a transrectal ultrasound, you're going to see a large central cyst. This is the correctable lung. When we see this, we are very happy. If you are not going to see this and going to see further away dilatations, these are not going to be correctable by surgery, even though they are ejaculatory duct obstructions. The MRI is far more specific if you are looking at difficult situations to diagnose, which means you have borderline dilatation of the ejaculatory duct. You're not sure whether this is dilated or not. You have other problems you can't identify well enough, and then you can look at the MRI.
So, sir, transurethral resection would be the treatment of choice there?
Yes, transurethral resection.
But what about the balloon dilatation, which has been very successful, and
so I'll tell you, the problem with any other procedure...
less complications, is balloon dilatation?
So the problem with any other procedures, they try to use laser also and balloon dilatation also. But the problem with this is...
For varicocele, am I going to have a permanent irreversible damage to my testicles? My question over here, the second part of the question is, after the operation, how much is the semen improves?
Either by laparoscopy, embolization or open surgery, which is non-microsurgical, the chance of injury to the testicular artery is between 10 to 15%. Now, thankfully, even after testicular artery injury, which means that even if you cut and ligate the testicular artery, not all testes will die. They will not all become atrophic. And we know this because there was a treatment for undescended testes where we would actually ligate the artery to increase the length and bring the testes down into the scrotum, Stephen Fowler technique. So, because we know that not all testes will die, in spite of injury, not all testes will get atrophic, but a significant number do, and almost 10 to 15% injury chance can happen. With microsurgery, it's less than 1%. So, with microsurgery, I can confidently tell them that your chance of complications or any irreversible injury is minimal. That's one. The improvement in semen parameters or sperm parameters is another important thing. Excellent question as always. So I'm glad you asked this question because unfortunately normally I always do one thing which I did not do today is put up the normal WHO semen analysis report. It is very important to understand that because a lot of our labs are still coming out with non-standardized reports. The WHO in 2010, in fact it's come up with 5 editions of this semen analysis, but the latest is the 2010 WHO report, and it has come out with these semen sample guidelines of collection and guidelines of assessment. In the guidelines of collection, the days given by WHO is 2 to 7 days of abstinence. Normally, we shrink it down. We make it 3 to 5 days of abstinence. That means you should not have ejaculated at least 3 days prior to giving that sample. Once you've given, when you give that sample, you've retracted the foreskin, cleaned the head with simple water. The sample is collected in a wide mouth container because you want to make sure that there is no spillage of the sample. Normally this should be done at the lab, but some people will not be able to give the sample in the lab, so they can do home collection, and you must be able to bring the sample to the lab within an hour of collection. We tell the patients that it is best to keep the sample at room temperature. They should not bring it in an ice bucket. The best thing we tell them is to put it in their pocket, in their front pocket of the shirt, because this remains at body temperature and that's the best temperature at which they can bring it within that hour. So those are about the sample collection. I'll quickly also mention what the WHO says. Contrary to thought, only 15 million per ml is the normal sperm concentration, and only 39 million of total sperm count is the normal sperm count required. 1.5 ml volume upwards to standardized reports. It's very important for you to have a standardized genesis. Very, very little sperm formation, not reaching the threshold to come into the ejaculate. To stimulate this, some centers started giving gonadotropins, HCG, or even oral clomiphene, tamoxifen. The idea was that you have to raise the intratesticular testosterone. So there are 2 very, very important things for this. One, your time duration of the therapy must be defined, and at your start point, the testosterone levels should be low. Usually these have been identified to be somewhere near the 200 mark. The third thing is you don't want to raise it above 600. That's the checkpoint. So once it's reached 600, beyond that the testosterone will cause a negative feedback again. You don't want that to happen. So you have to start it at a point where the testosterone is low. You use HCG here, some centers, Japanese people have used in very high doses, 5,000 units thrice a week. So you use it in fairly high doses, and then you normally will find that you will intervene at 3 months or 6 months.
Sir, one aam aadmi question is, if a patient is a smoker and an alcoholic, how much does smoking and alcohol interfere with spermatogenesis, and if the patient is agreeing to stop it, how much the count will increase?
So, smoking has a far more profound effect on both infertility or fertility and erectile function. We know erectile function because we know its impact that it has on the vascularity and fibrosis. It also has a significant impact on fertility. It's known to affect all 3 parameters, which means it's going to affect, in fact 4 now since we cause all the advanced sperm functions also. It is going to affect morphology, count, motility, and the DNA fragmentation. It's known to increase DNA fragmentation, known to increase the incidence of abortion rates even if you've had successful conceptions. And if there is maternal smoking in that, it multiplies this factor multiple times. So smoking, again, because any spermatogenic event has to be measured at the minimum of a 2.5 to 3 month window before you can see improvement, you will have to have cessation for at least 3 months before you start seeing improvement. It's slightly more complex with smoking because depending on whether it is only paternal smoking, paternal and maternal smoking, there are known to be significant effects. Alcoholism, until unless it is so severe that it is a chronic alcoholic case and then you are looking at hormonal changes, otherwise it will not have that significant. Social alcoholism will not have an effect.
Sir, our irony is that by the time the patient comes to us, especially the male patients, for infertility, they have been to all the babas and to a lot of people who have offered them a lot of Ayurvedic solutions. Sir, how much do they, those silver coated tablets and the gold coated tablets and the platinum coated tablets, how much do they interfere with the infertility? Most of the time it is counterproductive. Sir, your experience and your comment on that.
So I'll make two different comments on this. Now, one, to understand how antioxidants work. Now, when we're talking about anything, we're talking about even the use of antioxidants by us as clinicians. There is no evidence to prove that they work. We are all using it as empirical therapy. As long as you make sure that you use it for a fixed duration, and if you don't see the desired effect, whether we call it a placebo effect since it's not proven, or whatever effect, it is something that should be for a defined period. Don't use it on a poor patient. So normally what I will do is if I find somebody who I find not to be very affording, I will use zinc and anything which contains B complex and zinc and something which is far simpler available as a low cost thing. Because that probably will work as good or as bad as a extremely expensive coenzyme Q10 containing antioxidant. That's one part of it. The Ayurvedic preparations also have antioxidant properties, and I don't have, if I don't have proof against them, I can't talk saying that they are bad. But use them for that limited period. Be clear in your understanding that I will use it for 3 months in an old man because he's got limited reserve, wife has got limited reserve, and for 1 year in a young man because they have some reserve, I can give them some time with medical therapy. And once you've defined that, don't use it beyond that. Then if it does not work, offer other treatments. The unfortunate part is not actually this. The unfortunate part is the number of men who receive testosterone therapy for infertility. That's disaster. It's criminal to use testosterone therapy for infertility because it will lead to azoospermia. And I still find endocrinologists also using testosterone, currently also for infertility, and it is criminal to be doing that. All men who will receive testosterone will become azoospermic. And that's a fact. So using that is just not justifiable.
Sir, my last question.
Not only that, this increases thromboembolic events.
Sir, my last question. A 13-year-old boy, he came to my clinic with bilateral atrophy testes. I mean, very, very vestigial kind of testes. What is the hope for this patient and how should I go ahead and investigate this boy?
So this is the real trick question now. At 13 years, he is probably not attained puberty. So this examination of testes is going to be very, very difficult. You have to go by the Tanner staging and you have to actually measure according to the Tanner stage where he is reached and what is his level of development. The ways to go about for this is the stimulation test. So what we do is, even for delayed puberty, 13 is too early. Normally I will tell them to come back at 14 or 15. But for delayed puberty, we are going to stimulate with using gonadotropin. And when you give them this trigger, the internal circadian rhythm which has not yet happened gets triggered. And they start to respond to this. More commonly, your man will be someone, or your boy will be someone who has idiopathic hypogonadotropic hypogonadism. And if that is the case, this is someone who will require therapy for a very, very long time, lifelong. In fact, if you've ruled out other causes, you will need to rule out any pituitary causes and any other cause that you will rule out for hypogonadotropic hypogonadism. You will usually end up with lifelong replacement therapy. Here we actually, till he's not looking at fertility, give testosterone initially. So for their puberty, they receive testosterone. And about 6 months before fertility is planned, we shift to HCG first, and then at 3 months add HMG. So that becomes the replacement therapy for spermatogenesis. Very good testicular volume increase is seen in these patients.
I will say one thing. My voice is quite. I will say one thing only, that whatever we have discussed, last thing I will say, what we have discussed was very good, but we are impressed with you because the surgical impact what you were talking, that was beyond at least my brain. I can't think how to do, how not to do, not to do things. Refer to Dr. Virendra, Vineet Malhotra. We are highly impressed with you, highly impressed. Again to Dr. John.
My last
That is my policy.
We are highly impressed with you.
Your comment, sir. Your comment.
Small comment, I mean, like what you said for antioxidants, and it's also prescribed by the CSI and the RSSBI. Antioxidants have absolutely no role in metabolic disorders. And finally, for the sake of all the other, the audience out here, DIYOS is a one-stop shop for all the tests also that you have recommended. That is what I want the others to know also.
You are doing all the tests, sir?
Yes. Yes. All. So that's something very important for all of us in the audience.
So, friends, in the end, I think Dr. Vineet and Dr. deserve the